So with that, we're going to move over to Istanbul, Turkey, to join my friend, Dr.Omer Goktekin and Dr. Ibrahim Sari, who will take us through our next retrograde CTO PCI case. Omar, good morning, or I guess good afternoon for you.
Yeah, it's morning.
Morning.
It's
Morning.
8.
Early, even earlier morning.
Super early morning.
Even earlier morning. Thank you for joining us.
Thank you for having us. Thank you very much, Sanjog. It's nice to hear you. And I heard also Ramish's voice. Is he there as well?
Yes, Ramesh is here. Miroslav is here. I see Ajay in the audience. Srinivas is here.
Okay.
Arun's beside me. Dr. Tiwari, Dr. Kasturi. We're all here.
Hey, Omar.
Right.
How are you?
Hi. Thank you. Thank you very much. Hi.
Very good morning.
Yeah. So,
Okay.
thank you very much. First of all, for having us for TC India South Asia meeting. So we have a CX CTO case for you today, and my colleague Ibrahim Sari, we will do the case with Ibrahim Sari, and also my fellow Hashim Tuner, we will do the case, and our nurse is I2, and then technician is Taha. So could you please present the case, Ibrahim?
Yeah, sure.
Yeah.
Sure. Good morning, everybody. Thank you for having us for TCT India. Our case today is an LCX CTO. Next, please. Sorry, our patient today is a 60-year-old male gentleman. Actually, he has a history of dyspnea for the last 4 months. As of clinical history, he has a diabetes, which is non-insulin dependent, and he's a smoker. As of past medical history, he has a stent implantation for LCX in 2011, and then afterwards, he had a PCI balloon only for instant stenosis in 2016. Next, please. His baseline ECG actually was normal. As of echocardiography, ejection fraction was around 55%. There was a mild hypokinesia on infralateral wall and no significant valvular disease. However, there was mild pericardial effusion in the lateral wall, which is about 5 millimeters in diameter, and exercise test was positive. As of lab markers are non-remarkable actually. So you can see the angiography now. Just next, please. Yeah, this is the first image of our patient. You see that there's a total obstruction in the LCX. Next, please. Yeah. Okay. Gecikmeli gidiyor galiba görüntüler, değil mi? Next, please. And next, please. Next, please. Next, please. And next, please. Yeah, this is our patient's images.
So before you take the word, let's show us the what we have this morning as a diagnostic angio. My colleague had some picture. Let's see them. Yeah, this is RCA. The first shot is RCA. I think we have to me looks severe lesion at the proximal RCA, because RCA is really big. Distally is, I think, 4.5, and in that case, I think proximal looks to me severe, but we have to evaluate later on. And we have some collateral from right to CX. Next, please. It's epicardial one. It's not obvious here, but
it's like the distal end of the RPL.
Yes, it's epicardial. In here, yeah, we were able to see it. So hopefully we can open this integrate. If not, we will try to go with this little bit tortuous epicardial. We don't have better retrograde rather than this. Next, please. But I think we can work over it. This is CX, the left system injection, not seated well. And it's instant CTO. Next, please. And CX is diffuse disease from the ostium. Otherwise, I think CX is big vessel, not that small. We have 2 branches at the distal. We have breaching collateral, I think. we might have some channel. We will see better. Next, please. I think we have a breaching collateral. We have some collateral diagonal next. We couldn't clarify exactly. Play first and then frame by frame. In here, you see that we have some distal filling. I think it comes from the second diagonal of second branch. If we try to go here, we can do tip injection to see better, but we have some filling from here as well. So next, please. This is eleocranial view. Again, some filling to distal OM. Next, please. And bilateral injection. It's much better, obvious here. Distal filling from right coronary. We have epicardial collateral here, and here we see the CT is a stent which is occluded. I think we don't have that much clear channel, but in this view, if you see the stent, it's not that short lesion, but of course I have to find the distal landing zone, which is not big. That's difficulty of the case. I think that this landing zone is vessel is not that big. Diffuse disease. Next, please. Another view. Next one. So here I already place microcatheter, and this is workhorse wire run through to go proximal cap. And then next, please. This is fine cross. Why I choose fine cross? As you see here, if I have anything with nose, I would just prolapse to LAD, right? Look here. But fine cross, because he has no nose, I was able to push the circ. Okay, now we are here. We will start first integrate. Hopefully we cross it. If not, we will go through RCA. That's our plan.
So maybe with that, Omar, we will summarize the case for the audience here. We have a CTO of the circumflex in the proximal segment. There were some bridging collaterals coming off near the proximal cap. There is good collateralization retrogradely from the RPL system, but it is epicardial. It's good visualization, but it's a high-end epicardial to wire. And the plan is a primary antegrade. With respect to indications, you talked a little bit about 4 months of dyspnea. Did you mention what the mitral valve looked like? Because it's such a common presentation with patients that they don't present with chest pain. It is in fact dyspnea that they present with, and a lot of times as a result of either diastolic dysfunction or mitral valve abnormality.
Yeah, in echo, mitral valve was okay. There is no,
No problem.
problem. No matter regurgitation. We have mild pericardial effusion in lateral wall. That's all we have in the echo. Otherwise,
also an important finding to document before you start the case.
I was actually,
right?
when
I saw that when you were presenting it. It was so important.
so that is critical, right? I mean, if we had not done a pre-procedure echo, you didn't know about that small effusion,
Yeah.
monkeying around with the circ, and like you notice a patient has hypotension for whatever reason, that's going to have a very different connotation compared to like knowing this up front. So Sanjog, let me just kind of pick your brains on this, right? So this is an ISR CTO, looks like. So when it comes to ISR CTOs, I mean, obviously where the proximal cap is, if it's within the stand outside and distal cap within outside, that's going to kind of help. I mean, and you have the whole classification, right? So just for the audience, like if you want to just talk about a little bit of how that influences your strategy.
Yeah, so I mean, your highest likelihood of success is going to be an in-stent CTO where your proximal cap is within the stent and your distal cap is within the stent. And generally speaking, you can divide those up into the age of the occlusion. So if it's relatively early ISR, what you're typically dealing with, and you can see that this is floating across nicely, what you're typically dealing with is is neointimal hyperplasia that's been occlusive as a result of a mechanical issue within the stent. If it's later, you may have neoatherosclerosis, which is going to be calcific and collagenous and is going to require a completely different wiring strategy. Okay, and so we're across something.
But I think key point, Sanjay Ajay, here is that rather than keep advancing the wire, he stopped and took a retrograde shot to see where he's at. And one thing you can also do, by the way, is while the dye is in the vessel, then you can gently advance. We used to call that the DK maneuver in honor of Dimitri Kampaliotis. But there's so much of a tendency to just keep advancing the wire, and that's how you lose the case. Because if you're out the bridging collateral, you're out the pericardium, you're going to miss. And in this case, very nicely done. And you'll see you change the view a little bit too, to be sure orthogonally is okay. And with the dye in the vessel, you can then advance the wire and just show that it's in the right place.
So we don't have that much enough flow from antegrade because I think we occupy something there, a little bit less. Let's see from the right.
I think this is where your retrograde from the right is going to really help you. And
yes, exactly.
You can, without concern, advance the wire forward because if you're out, you're out. As long as you don't follow it with a microcatheter, you're fine.
Which wire you are? What wire do you have?
What wire did you choose?
Gaia second.
All right, this is Gaia second, the first wire. But let me make sure if I am in the lumen. And so. It was Gaia second. I a little bit push my macro a little bit, yes. And then I think I am in the lumen, but let's see. In here, I don't mind.
Once again, you haven't taken the microcatheter distally until you know where your wire tip is, but there's nothing wrong with moving the wire forward so long as it's not knuckling, because if you're out, you're out, and if you're in, you're in. And if you're subintimal, that's not the end of the case. It's just a change in strategy.
So let's make sure, right? So distally, I'm not that happy. So let's change the view. We can go maybe a little bit areo.
Perhaps one of the other options is to selectively engage the collateral with a microcatheter and do a focused injection from a retrograde microcatheter. That may help with some of the visualization.
All right. So definitely my wire is not happy. It looks easily crossed, but I don't know. Let's see. What are you? Can we have some control? But let's do bilateral injection. Yeah.
So again, for those people that are getting started with CTOs, I mean, the key take home is like, it's okay to advance wires. Don't advance your gear until you know the position of the wire.
I think what we see is a lot of contrast blowing back into the aorta, Omer. And so you're not really opacifying distally, the guide's blowing back. And so this is, again, one of those things where you may find some utility of getting a microcatheter into the RPL and doing a selective retrograde to be able to target the visualization to the retrograde end of the wire.
Also an important point
so
here.
I want,
you generally
guys,
don't...
I think I am the lumen at the more proximal part. I feel it. So, but later on, my wire maybe go...
Yeah, I think just for the audience, I think it's, with a very experienced CTO operator, you can tell by wire behavior, visual, tactile, feel, these kinds of things. But in general, the principle is you don't advance the base of operations until you know where the tip of your wire has gone.
And typically you don't want to do antegrade injections.
Precisely, I was just going to say that.
But because he feels that he's in stent and he hasn't advanced the microcatheter further and it's kind of plugging in. So you can do that a limited amount, but you pretty quickly have to then switch to selective injections to avoid.
I think, if you've got just ipsilateral collaterals, then one of those ways is to get a microcatheter down the ipsilateral and do selectives. In this case, you've just had a single wire across through the proximal cap without a whole lot of change to the CTO segment. So hopefully you won't advance any dissection planes early.
Hi, Omer. Yes, parents. Hi, Omer. I think your XB wire or EBU wire is definitely too small. So you will have some troubles with support. So I would choose, definitely, I would change to larger one. Then you will have much easier approach.
Yeah, okay, I agree with you. Here, what I have in my hand, I have a hydrophilic wire and I believe that I crossed already the CTO part, and I have soft hydrophilic wire, which is this is Sion black, but yeah.
Yeah, so recognizing the hydrophilic wire, the polymer jacket means your tactile feel is gone, right?
Yeah,
and entirely how it behaves visually.
Exactly, and I thought that it will go if it is in the lumen, it will go distal, but the same thing happened. I have some resistance
behaving
here.
like it's in the true lumen right now.
So this is a great teaching point, right, Sanjog? Like in terms of not advancing a stiff wire such as the Gaia second, what Omer did, although he's super experienced, is like, well, he thought he got through the CTO and it's just navigating some of the disease segment. So he took a hydrophilic polymer jacketed wire, which is much safer than Gaia.
Or even a
workhorse wire, right?
Yeah, typically you just take a Xi'an blue at
Xi'an blue or a run through or whatever you got.
Because that will give you still some tactile feedback, some visual tactile feedback. One of the wires I like doing in that situation is just a regular Xi'an.
Yeah.
Okay, that looks good.
That looks good.
There we go.
I'm not sure where am I. Let's see, but Xi'an wouldn't do that, right? Xi'an blue, I think, because it looks like to me. I'm not sure still what I did. Let's see. Still, I want to know what I did. I'm not sure the scenario. If I crossed after the bifurcation or not, I'm not sure. We have a bifurcation there. Let's do some tip injection here.
So maybe before you do the tip injection, you're going to pull back, right, and see that you're getting blood back.
Yes, exactly.
Because obviously, if you're doing a tip injection and you happen to be wrong, and in the subintimal space, your case is done.
Case is done either way.
So we try to avoid doing that until we've confirmed that we've retrogradely visualized the location of our distal base.
Exactly why I do this, Sanjog, to see what is the bifurcation. If I don't see bifurcation, I believe that I crossed after bifurcation. So that's why that's why I do this. Otherwise, I wouldn't do that.
Exactly. I think that's the important point, right? Is to recognize that you're not going to do a distal tip injection until you can prove where you are. And I don't know where you are there.
Yeah, so I would say
the microcatheter itself is
for the less
we don't know if it's beyond the bifurcation or not. Right? I think
I would not
you would try to avoid tip injections and instead visualize retrogradely, just in the in the interest of the audience that we've got, where some of them are just starting their programs.
I think this is a very good way now to change your microcatheter to double lumen micro. This is will be very, very helpful.
Okay. Yes, you want me to wire CX as well, right? So yes, that's a good idea. Definitely, I agree with you. Do you want me to do some dilatation all the way, or what do you think, guys? So before inserting double lumen.
Omer, one quick question. How big was the other branch? Is that something that you want to save?
I want to save. Yeah, it's not small. Yeah, I have to have it. Yeah.
Then I probably would vote for dual lumen catheter, secure the branch.
Either that or limited ballooning just proximally and then an IVUS to define where your reentry site is. Yeah, because I think that's probably one of the most important uses of IVUS in these scenarios is to prove where you've reentered.
Exactly.
So Omer, we're going to let you work on that. Our next case site is ready and we'll be coming back to you in a short while.
Sure.
We look forward to seeing what the progress is that you've made. It looks like we're ballooning, which is great.
Yes.
Maybe we'll recap a little bit of what you've done.
Yes, sure. What we did, next please. We did 2O balloon after remove microcatheter. Next please. Yeah, next. Yes. After tip injection, you left here, and then we did 2O balloon from proximal. Next, please. Next. And then we had some contrast, and we see that's okay. I think we are happy for the bifurcation here, and I think that's moment may not be necessary, because obviously it's come from, I think, true lumen. We send double lumen catheter, which is Sasuke. Next, please. And we took the same wire, which is Sion black. We give give him a little bit more angle.
A tip.
To go side branch. And now we are pushing. We recorded it for you.
It's great. For the audience, Xi'an Black is a polymer jacketed, approximately 1 gram, slightly less than 1 gram tip with an Act 1 core. So it's a 1-to-1 torque control wire, which is very nicely suited for just this task, which is accessing a side branch after the CTO segment.
It takes a couple of seconds to cross, but after having nice direction, you see all the time I couldn't give a nice direction. It went, that's why I went that part. So as soon as I give a good direction, it went side branch.
Very nice. So now
which is, I think, now, which is big branch, right? Not that small.
Yep.
Absolutely.
So after inserting this, we did again trapping, and then we changed this wire to run-through wire, which is workhorse wire, and we did 2.5 balloon. And no, we did this after. Yeah, okay. This is 2.5 balloon, 30, and then we have another injection. We have some kind of, what do you think? This could be hematoma, right? Why we have this? Next, please. We have better image. Distally, I think this appears because we have now both antegrade flow, but retrograde flow as well. That's why I think we have this kind of dissection.
You can see a to and fro sort of appearance just in that secondary branch there.
Yeah.
You wonder if what that suggests
dissection.
is the disease proximally, the disease proximally in that branch is very tight.
Omer,
which is why you can still get that.
Have you
show me the
perfect.
iris, please?
I was
Show
just
me the
gonna
iris.
ask a good image
Iris
to-
good.
They're going to do that now.
And for the audience, that's like the key thing here, right? I mean, you think maybe there's a dissection, maybe it's, competitive filling, etc. But like, just put in an imaging catheter, take a look, see what's going on,
Precisely.
and then come up with a strategy.
We've moved away from the idea of guessing now, right? Now
So
we're at the
here-
point where we can
here,
do it. So here you
that's
do
the
have
part-
a little bit.
And here we have the hematoma, I believe, a little bit.
Mhm.
Distal bifurcation here.
Although
And
it's
we are
hard,
having now OM.
it's hard to tell if this is hematoma from wire
Okay.
or if it's
In here-
hematoma from
Okay,
advancement
all right.
through
I agree
integrated
with you. I
injection.
agree with you. I agree with you. In here, please look at it. I think we have wire based dissection now. I'm in the common CX now.
So everybody
But-
sees from about 7 o'clock to 11 o'clock.
Yes,
along the side
exactly.
Of the ibis,
See-
there
see
was
now?
and
Yeah.
now it's on the other side.
Yeah. So I think it's
Between
done by
all
integrate
six.
wire, the first wire.
Mhm.
But I am in the interluminal so far, and I
Yep.
came to stent. Stent, I think well opened because they did, second intervention to have a post dilatation and then, better expansion. And now you see, I'll have a small channel, which will be appears 11 o'clock.
Right.
That one, the channel, but we couldn't cross through that one. That's I think it's still there,
Yep.
small one.
You can see that channel at just like sort of 10 o'clock there. That's
Yeah, and then this is total occluded part.
fibrous plaque. Some
Yes. And then here vessel is around 2.0 easily.
It's quite large.
Yeah, and then this is proximal part, and then we have left main, which is
So the
Really
question is, why did the stent close, and how is that going to affect the treatment strategy you
the
employ?
test
now?
alone.
Yeah, that's probably the hardest part of this whole case.
Right.
This patient has been stented twice, right?
Well,
Omer,
why
in
did the
past?
stent fail?
No, once. I
Just
think.
once? Okay.
Yeah. Bir defa değil mi abi?
Yani 2016'da
So.
yapmışlar. 2016'da balon yapmışlar.
Yeah,
I think we do have to be careful with
That's
the
a
antegrade
dissection.
injections at this point because we
exactly.
know. But I would avoid antegrade injections because you can see
Exactly.
that injection starting to move.
Let's
into
put
the branch.
let's put a stent to
We're gonna
distal,
lose
right?
that.
I think. What do you think? We have to do something about that.
I think the bigger of the two branches is probably the lower one, which with that.
Yeah,
disc
it's very big. And then I did 2.5 balloon after I was. Then I like to see the result. But you are right. We shouldn't keep
I think
doing
we
antegrade
should
injections.
avoid antegrade injections at this point and actually secure that distal vessel with some sort of stent.
Bakın.
so that you're not worried about even blood flow advancing those dissection planes forward. This is the whole idea of contemporary ADR type.
I think that part
protection.
is, to me, is hematoma. I think, Sanjog.
Yeah, I think we're all in agreement that there's probably hematoma there, and there's maybe a little bit of advancement of the dissection planes with contrast past that bifurcation. And so the question becomes, how are you going to deal with that? Are you going to try to secure the distal with a stent? Are you going to pop that hematoma with a cutting balloon and see what you have? Arun, how would you?
But the consensus here, I mean, like, I think, the big principles, no more injections antigrade, right? You already have imaging, you know what you're dealing with. I would probably start off with, like, take a Wolverine, get it down there. I mean, you've got a lot of hematoma, decompress it. And now the big question is, you already have a layer of stent in there. You want to use like DCBs, and then just walk away. You want to stent this, but I think I would probably start off with cutting balloon first, decompress the hematoma, take care of it, and then go from there.
This is sort of where we were going before, right? Which is, what's the mechanism of failure and how is that going to affect what you're going to end up doing? So I think here we have two problems to solve. One is that dissection plane within that large distal branch, because if we lose that branch, then we know it's a 2.5 millimeter branch. Loss of those branches in CTO PCI is associated with an elevation in MACE, and it's not what we want to have. And number two then is, what's the approach you're going to take to treating the proximal part of the vessel? And that comes down to why the stent has failed. Right? So Omer, what do you plan on doing with the distal end, the inferior branch of that bifurcating? Vessel.
Guys, yes, that's the point. We have to decide. Normally, I want to do stent in stent. Here, let's do seal distal part with a stent.
I was just going to say.
And do aggressive dilatations like 3.5 and 4.0 in the stent, and then see the result, and then decide if we cover just unstented part or we will come from proximal. What do you think? Because I am not sure.
I like the idea of securing the distal vessel right away, so that it doesn't end up losing your final result. We can stick that with an appropriately sized stent, given that we have imaging and we know that vessel might grow down the line, so you can make it bigger. And then proximally, I think there's more than just the question of DCB versus stent to answer here at this stage after expanding it. We need to know how big that stent was and what type of stent it was when it was put in, because that's going to affect how big you can make it and what the platform tolerances of the previous stent are. Once you have that information, you can decide whether or not you want to make it bigger, though I think you're probably going to want to stent that distally, you're going to want to stent it proximally, because it looks in the proximal segment anyway, that stent is way smaller than the vessel actually is.
Actually, at the first, I like to do DEB all the way here, but it couldn't happen. I like to go up.
I also feel, I think preferable to do the emptying that belly is very important, intramural hematoma, because sometimes what happens, it squeezes too distally. That hematoma.
As long as if you land within normal vessel, it's less common to do that. The problem is you can get positive remodeling late, which but then that hematoma will end up with positive remodeling.
Behavior of the intramural hematoma, if the normal segment is there, it can spread fastly, but disease segment, it will not spread. At the branches, it will not spread. So that's the reason distally vessel appears to be normal and the dissection is much bigger. I think if we are doing, I personally feel if take the cutting balloon 2.25, empty the intramural hematoma, stent it, sometimes we may escape, but preferable to go ahead with that.
Looks like we've moved forward. So that's a stent, Omer, that you've put in?
Yeah, this is 2.5. We will expand it to 2.5/26 resolute.
Omer, what's your strategy for the proximal part? Are you going to restent it? Are you going to do DCB? What are you thinking?
Exactly, that's what I'm thinking.
So what was the previous stent, Omer? What kind of stent was it? Do you know what the previous size was? I mean, if that was a 2.5 stent in a 3.5 or 4.0 vessel, 2.5s don't go to 4.0, right?
No, I will expand that my stent anyway. At least 2.5 at this part, but proximally it's 4.0. So let's do some dilatations, proper dilatations. The stent, for example, for the stent, I want to go 4.0 for sure. Let's see the result. If the result is perfect, I mean, very good, we can do DEB at the stent part, and maybe we can put a small stent that we have a gap here we may, if we need it. I mean, otherwise, would be happy to do all the way DEB. What do you think?
I guess the only comment is if that previous stent is a 2.5 stent and you expand that to 4.0, your radial strength of that 2.5 stent is compromised because the platform is not meant to get that big without becoming rigid. Now, this is a relatively straight vessel, so your risk of stent fracture is low doing that, but it's not zero. And that, I think, is about the only place where you might get proponents saying you want to re-stent. But if you've got a good stent expansion result and a platform that can get as big as you want to get, a DCB is very reasonable.
Yes, I agree what you said, because one should also
please see the IOS
concern
again,
about
guys.
the osteo of the circumflex, comparing the distal vessel.
The importance of the history in interventional cardiology. We're more than just stent jockeys, right?
Go up here, 14. So if you see my IOS, stent expansion is good. It is reaching 4.0. This is, this is 3.5 balloon up to 14.
It started to look pretty good proximally, or in the mid segment, I should say. Proximally started to look a bit small, but that's also undergone Glagoff remodeling, right? That's probably also bigger than it needs to be. So here you've got non-compliant balloons. You're making it bigger.
Yeah. Now I'm in the stent. 20. I'll do a bigger balloon here.
Great.
According to IOS. I'm happy to do DB here if I could.
So now that you're expanding this up bigger and you've got a stent distally to protect the bifurcation, maybe we can see an angiogram there and see whether or not we're happy with the result and decide on whether or not a DCB is a reasonable approach. And I think that the truth is we don't know, right? We're still learning about these things.
I'll do gentle dilatation here. Down. Let's see. I wish I could do DB all the way without any stent, but it couldn't happen.
I think we all wish we could stop leaving metal.
Yeah, it was my the best option.
It's interesting. You speak to the Europeans, and I hear from a lot of them. In the UK, for example, where a lot of their distal lesions they're not stenting anymore, and everybody's DCB. But it's important to recognize those data are still developing, right? Yeah.
Even CTO we use DEB these days. Yeah, we have a series now, and I believe we will collect our series with the Arun series. Arun, I think, does that as well. Yes, Arun, you do.
Actually, here DEB will not work. Angiographically suboptimal results as per the guidelines.
Yeah.
If suboptimal result, like a residual is more than 30%, and definitely stent is must. Maybe the intrastent tissue is more, like a neoatherosclerosis is more. When the neoatherosclerosis is there, like a native vessel, you have to stent it. So if you do the DEB for this patient, results will not be good.
So therein lies the challenge, right? Is maybe a stent proximal to the one that you placed briefly with a DEB more proximally than that, so you don't have to stent all the way to the ostium of the circ. Doesn't mean there has to be just one solution. One short stent into the proximal part of the circ to cover the underexpanded or sort of high tissue burden area of stenosis with DCB more proximally to that may work. We'll let you work on that, Omer. We're going to switch back over to Dr. Bali here for a few minutes.
Yes, but before you leave, Sanjog, so let's decide really. So what I want to do, if you agree, I want to do 4.0 dilatation if everything is good for the stent. If I like the result, I will do 4.0 DB for stent, maybe a little bit proximal, but this total stent, I may need to put another stent, but I don't want that much overlapped.
I think that's a great plan.
I think that's a good option.
We're in precisely.
Yeah, let's give a chance. Yeah. I don't like stent anyway.
I think we're all on exactly the same page there. Let's go to the final result in a few minutes. We'll be back to you in just a little while.
Thank you very much.
So maybe we'll jump over actually just to Turkey for a moment to see Omar's final result before welcoming Dr. Pounami up for his talk on laser and CTO PCI. Omer, you're with us again?
Yes, thank you.
Looks like you're all done.
The lead's off, so it's a good sign.
Yeah, yes. We are drinking our coffee now. So this is what you left us. We put a stent distally after aggressive 4.0 dilatation. We like come back. This is after post dilatation of 4O. We like the result. Okay, so we just covered that part with 3.5 18 stent. Next, please. Next.
That's right. So with good, it's good. You presumably you put a 3.5/18 into the mid vessel. This is interesting, given that the proximal stent looked like it was about a 2.5, and this is distal to the proximal stent. So speaks to the importance of imaging to define stent sizing.
So after 3.5, we did 4O dilatation from the distal. Okay. We came from distal. 4O aggressive dilatation intrastent. Next, please. This is after 4O dilatation. We like the result, and we did DEB, which is 4O 35 magic touch. Because we occlude the artery, we just stay 30 seconds, not more. Normally we stay more, sometimes 2-3 minutes in CTO. And this is after DEB. And then we did kissing at the distal because we like to have better.
I was going to ask you what you did about that.
Yeah, 3O for CX, 2O for the side branch. We did kiss.
Was it easy to rewire?
It was easy. It was easy. Yeah. And then this is the result. And we had IVUS. Next, please. IVUS'u göstersenize. We did IVUS. Next, please. And after we did some last images without wire. Next, please. I think these results is good. And we didn't put a, stent at the intra-stent. Let's see. We will have this patient after 6 months. This is the IVUS you see. Başından beri gelsene. Başından mı geldin? Başına gel. Let's see from the beginning. Neredesin Taha'cığım ya? Başa gel.
Beautiful stent expansion that you see throughout that.
Yes, exactly. I like
segment.
Yeah.
And also a very good example of where the pre-PCI IVUS was a critical determinant of what your strategy ended up being.
CX. Yeah, exactly. I fully agree with you.
There's a lot of this business of putting the imaging in after the stent is in and then having to clean up what is a suboptimal result. But here you've got the pre-PCI IVUS as well as the post-PCI so that you can actually design a rational strategy. Lovely stent expansion throughout the circumflex here as we pull back.
Yeah.
Fantastic case. Thank you very much.
Thank you very much for having us. Thank you. See you later. Bye-bye. Thank you very much.
Thank you for joining us.
Fantastic result.
Great job.
Sanjay.